Next slide. So for our first session for our Unit 2 really focused on traditional healthcare settings, we are talking about compassionate conversation, so really integrating harm reduction in our clinical care spaces. Next slide. So we already did our introductions and announcements. Next, we'll get into our presentation with our wonderful speaker, who I'll introduce in a second. Also, a big component of ECHO is the case presentations or case scenarios, where audience members have submitted a case or scenario, and we'll talk through that with our subject matter experts, as well as participation from the audience as well. And we'll then end with like closing remarks and our evaluation as well. Next slide. We also really are wanting to foster a collaborative and brave space. So really the space is intended for learning, but also unlearning. And we know that sometimes unlearning can be harder, and really growth for all, regardless of our background or level of expertise and experience. Next slide. Okay, so I get the honor of introducing our speaker for today, who is also one of our subject matter experts. Greg has spent the last 6 years at as a harm reduction nurse for Choice Health Network in Knoxville, Tennessee. He established and implemented medical services within their SSP, including rapid and confirmatory blood draw test for hepatitis C and free low barrier wound care. Part of his role involves educating the local medical community and students about harm reduction practices and how they are incorporated into modern medical environments. This work includes creating and managing Choice Health Network's harm reduction program, as well as clinical rotation sites for the University of Tennessee's College of Nursing, UT College of Pharmacy, and the Substance Misuse and Addiction Resource Tennessee, also known as the SMART Initiative. Next slide. So we'll get into our presentation. Next slide. And I'll hand it over to you, Greg.
Awesome. Can everybody hear me? Yes, perfect.
Yes.
So yeah, hey, I forgot you were doing the bio, which is great. I don't have to tell everyone who I am. But this is the Compassionate Conversations Integrating Harm Reduction into Clinical Care. Basically, the way I approach this is just kind of harm reduction basics 101 for medical professionals. It's not something we were taught in school, and so there's hopefully just kind of a introduction to it if you don't know anything about it. If you do know about it, hopefully it's a different way to think about stuff. Next slide, please. So yeah, my name's Greg. I've been a nurse for a little more than 10 years now. Just a background about me. My hospital experience is where I first started practicing. So I did cardiac for a little bit, but most of my time in the hospital was done at labor and delivery at 2 major university hospitals. And then since then, I've been an outreach harm reduction nurse here at a syringe service program for more than 6 years now. And we serve 4 different counties. So we have rural spots way out where there's no cell phone reception, and we also work in downtown Knoxville. As a warning, I like to tell people I do talk fast. I apologize for that. I'm trying to slow myself down, but my email address will be at the end. Please reach out with any questions, comments, concerns, if you have anything that I didn't follow up on. Next slide. A couple disclaimers I like to just say is I'm a nurse. I'm not a high-level provider. I can't prescribe. I'm not a lawyer. I'm not a medical center administrator. I don't do any of those things. These are just my experiences and my education I've got as a nurse. The recommendations and suggestions I'm going to have are broad. They should be considered in context with the organization you work for and your company's own policies. And one thing you should do is know your own policies and why you have them. And most of the knowledge I have today comes from serving people at our SSP. I was not taught about harm reduction in nursing school. I was taught kind of to stigmatize against people who use drugs in nursing school. And so me doing this is trying to be an advocate for those people that I see and take care of that are not going to traditional medical systems because of the stigma they get. Next, please. So these are just a couple of group agreements that whenever I'm talking to College of Nursing or anybody, I like to kind of just say, like, this is where I'm coming from, and this is our baseline. Drug use is human history. I always challenge people to think of a time in our human history that substances weren't being used. I don't care about illegal or illegal when I say this. I'm just talking about substances. If you were looking at it through a legality sense, then about half the country 5 to 10 years ago was horrible if they were using weed, but now because it's legal in those states, it's okay for them to morally also, right? So substances go back and forth, legal, illegal, just based on politics, but they've been used throughout human history. And then also drug use is a continuum. It's not A or B. It's complete sobriety, abstinence, and then chaotic use, right? And people go back and forth along this day to day, hour to hour. It doesn't have to be you're set here, you're set here. You can move back and forth depending on your situation, depending on your environment, depending on your emotions. And so just knowing that we all move back and forth with our substance use throughout our life is a good thing. People don't have to be set at a point and go to another point. Also, it's not like this is the good side, this is the bad side. It's just the continuum of drug use. And then words matter. Stigma kills people. And genuinely, I do mean stigma kills people. People do not go to hospitals, do not seek medical care because of the stigma that they are getting from those places, and they die because of it. And so choosing the words that we're using is super, super important. An example I always like to talk about is if you're getting a report from somebody and they're talking about the patient in room 3 and they're going down, they have these medical conditions, and then they use terms that are stigmatizing to talk about someone's substance use. That doesn't really help you medically take care of that person, right? It just helps you form a bias against them. So when you go in that room, you're already treating them in a worse way. It doesn't help you medically at all. And so the language that we use to people and about people is super important. Next slide. So what is harm reduction? There's been around for a long time. There's kind of big H and little h harm reduction. Big H harm reduction, social justice movement that was built in the belief and respect for people who use drugs. It was that easy. Just because you use drugs doesn't mean you should have less healthcare. You should be treated poorly. You should die. And then little h harm reduction is just practical strategies that reduce negative consequences associated with drug use. Harm reduction does not pretend that there are not negative things happening with drug use. That's okay. It just accepts that, and there's practical strategies to reduce the negative consequences with that. These are the things, the little h harm reduction, these are the things that are actually more applicable to most medical settings, because most hospitals can have these little practical strategies. And this is what most of our work at SSP is day to day, is the little h harm reduction. Next slide. So harm reduction within a medical setting, what does it look like? How can you incorporate it into your practice if you're not working at a syringe exchange, which the majority of people are not working at a syringe exchange as a medical person? Florence Nightingale, for people that don't know, started nursing as we know nursing. And I saw this quote, and actually I loved it, is the very first requirement in a hospital is that it should do the sick no harm, which I agree with, but I unfortunately don't think the traditional system that we have in the United States currently follows this. Next slide. So this is just a comparison between traditional medical approach and a harm reduction approach to care. This is not like this is a harm reduction hospitals approach. It's just a harm reduction mentality to caring for people. Traditional medicine, it has a provider directed endpoint. Who tells you what the endpoint is? The highest level provider in the room. It's hierarchical, which means that the highest level provider is here. Then you have mid-level, so nurse practitioner, PA. Then you have nurses. Then you have nurse techs. And then at the very bottom is the patient, right? Like we're all taught that we should be patient advocates and the patient is part of the decision-making process. But in reality, we know that doesn't exist fully as it should. It's didactic. It's moralizing. We shouldn't moralize healthcare. Just because someone does something that you may not agree with like that doesn't mean you shouldn't provide them the best care possible. I, as a nurse, like to hope that everyone else in my field does this because they want to care for people, not because they want to care for people only that they agree with. It's time limited. So how many of us get to go to see our primary care provider and get to spend more than 5 minutes, 10 minutes, 15 minutes with them? Nobody. And that's not, I don't put the blame there actually on providers. I think it's because of like insurance companies and stuff like that. And so it's incentivizing us to see as many patients as we can because we can bill insurance more. It's the financial side of it. And then also incentivizes efficiency. It is getting, 2 patients booked every 30 minutes because it's efficient that. It's sending people, if they want to go to treatment, for 28 days because it's efficient, not because it's effective compared to that. So this is the traditional medical point or a medical care model when we're looking at patients. A harm reduction approach to those things is we can have a collaborative endpoint. When you're in the room with a patient, have them, talk to them about what they want, meet them where they are, and try to figure out where they want to go and help them get to that point medically. It doesn't take away our expertise as medical providers by letting the patient help make a decision with us. It's not saying, oh, you're also as smart as us, you went to school at the same time. It's not taking that at all. It's just taking them in part of the decision process. Um, it respects their autonomy. Everybody should be able to make their own medical decisions about themselves. We don't need to make them for them. It's not moralizing, like I was saying. We don't need to moralize the healthcare we're giving people. It just because they do something that you may or may not agree with does not mean you moralize, you make them feel bad in order to receive medical services from you. It's also ongoing. I understand that, again, we don't as providers technically get to decide how long we see our patients, all that type of stuff. But if we can have the process be longer, if we can see people more frequently, if we can elongate that care process, people will be more comfortable, they'll be more trusting, and it will just help their overall health throughout time. And it incentivizes any positive change. That's kind of a big term. If you heard harm reduction at all, you hear it, that phrase, honestly used all the time. Any positive change, but it truly is. So when people come and see us at the exchange, a positive change could be I'm using a different amount, or I'm injecting in a spot that doesn't have scar tissue, or I'm smoking, or I have a job. It doesn't even have to be medically. Any positive change that a person has, because there's that massive power dynamic between medical providers and patients, if you show excitement, if you show joy for them and positivity, it really, really helps out your bond and it helps support that patient. Next slide, please. So what does harm reduction look like? Kind of like I said, it respects and promotes autonomy. It respects people's decisions, even if they're not ones you would make for yourself. There's times that all of us who have had patients somewhere has had a decision that they've made that you may not want for yourself, you may not want for your siblings, your family, your friends, but as a medical provider, you need to provide them with the best care possible, regardless of if you want it for yourself. And it meets people where they are to support them. This can mean physically meeting people where they are. If they're not coming to your medical practice because of transportation issues, financial issues, if they are unhoused, going to where people can be is important. It's meeting people where they are with care for finances, so having different levels of pay options for people. It's meeting people where they are and supporting them by being genuine with the care you give people, and non-judgmental with that. And it doesn't mean you have to agree with everything they're saying, but people can really tell when you're not being genuine and supportive. They can tell when you're looking down upon them. And so learning how to be genuine in a supportive way that just doesn't compromise the way you care for people is important. Next slide, please. So these are things you can do depending on your company's policies. I always put that there. So I understand a lot of harm reduction stuff I get to do because I work at a needle exchange. I understand if you work in a hospital, you can't do some of the stuff. That's completely fine when they say that, like, it makes sense. But these are just some things you might actually be able to do within your practice. Who knows? So services you can provide. Vein finding, wound care. When I say vein finding, I mean if you're trying to reduce the harm that potentially comes from injection drug use, I don't want people to miss. I want people to get it in their vein the first time, every time, right? Because if I'm trying to reduce soft tissue infections, I'm trying to reduce any of those things, I want people to know how to find veins. I was taught how to find a vein because I'm a nurse, but people who are not medical professionals may not know. And so helping people know what to do helps them have less harm from that. Also, wound care. People get wounds all the time, and then they go to the hospital and they're discharged without proper wound care. So either they don't have the proper antibiotics, they don't have the proper wound care supplies. Those things are super important. And so what you can do is you can provide basic wound care. It's not high level, really, really high level. Sometimes it is, but most of the time it's basic stuff that you can probably buy at like a grocery store, and teaching people how to take care of it, teaching people what not to do. Stop washing your wounds with hydrogen peroxide, please. Those things are important, and it builds trust and rapport with your patients. You can also do Hep C, HIV, STI testing if possible, and linkage to care with reputable places. And that means places that don't have sobriety requirements, places that aren't going to require people to stop using in order to get your hepatitis C and HIV treatment. So if you're going to link people to care, know where you're sending them also. If possible, you can provide injection and overdose prevention supplies. If you're a place that can provide syringes or stuff to go along with that, awesome, you should do it. If you can't, I get it. But if you could also pass out naloxone, That's super important. Having also different options for that. When I say different options for naloxone, different like doses. So there's the different types of nasal ones. There's different like amounts in it, and also there's an injectable one too. And so teaching people which one is good, if they, if they're going to leave it in their car, what to do because of temperatures, just having that array of type that's out there, and having education behind it, like the difference between the 3 milligram or the 4 milligram or the 8 milligram nasal one, and why we don't really want to give the 8 milligram one out. It's just important. And drug testing tools. If you can give out fentanyl test strips or xylazine test strips, that's awesome. Because again, if people can test whatever they're using to see if there's something like fentanyl or xylazine in it beforehand, it allows them to make the safest decision possible they can make before using those drugs. And then kind of everyone can do this. Your company's policy doesn't require it. Be nice. Offer a non-judgmental space. If your space is kind of sometimes sterile feeling, or if you feel that your space has things in it that might be judgmental towards people who use drugs, try to get rid of those things. Try to offer a place where people are treated with dignity. They're listened to regardless of if they're using substances or if they're making decisions that, again, you may or may not make with your own healthcare. Next slide, please. So these are things that we hear all the time. Why can't someone just go to treatment? Or why can't you just go to the hospital? Or why can't someone just take their meds? There's a lot of reasons, right? And some of the reasons that are out there is stigma and discrimination. Internal stigma. We've heard this all the time. Accessing care puts you in a very vulnerable position, and it can bring up a lot of shame. And so people sometimes don't want to go because they have a lot of internal stigma. That internal stigma, a lot of it comes from external stigma. Unfortunately, a lot of it comes from the medical field. And I say this as a person who works in the medical field. I understand it. It does make people feel bad. And I know this because people come to us and they talk about it. So past negative experiences keep people from getting care. And so anytime we have a bad interaction or a bad relationship with a patient, we got to be thinking about, did that potentially make it so they may not come back to us in the future? And as a medical provider, hopefully that gives us pause, and we want to figure out what we did wrong so we can get them to come see us again in the future. Insurance status, money for prescriptions, visits. Just because you have insurance doesn't mean you're insured enough. We know that. A lot of people are also uninsured. Ability to get to your appointments with transportation. If you live in a place that has public transit, great. If you're in Tennessee, probably not the best, which all of us are. Being able to take time off from a job if you have it. If you don't have a job, still being able to get to a place with gas money, any of that stuff. Those are just reasons people can't make it all the time. And then also meds. Meds are hard to get. They cost a lot of money. If you're unhoused, you might lose your stuff sometimes, and it's hard to get medications paid for again. And then coercive services that force people to get drug treatment as a necessity to require medical care. We know coercive services for anything do not work. And so if you're forcing someone to do it, you're forcing someone to do A in order to get B, when what they wanted was B. Well, A is not going to work, and they're probably not going to get B anyway, so we're just worse off here. And there are articles and stuff to support this. I didn't put any of this in here because it's a pretty quick presentation, but if you have questions, email me afterwards. Next slide. And these are just a couple closing reminders that I have to tell people how to incorporate it into your practice. Most people aren't working in a harm reduction space. I get that. But these are all things we can easily do as medical providers anywhere. Is listen to a patient's healthcare needs. Do not assume that their needs are connected to drug use or that they are drug seeking, and allow them to guide the conversation. Respect self-knowledge, live experience, ask clarifying questions. Those things there, like people come in and they'll say stuff that I don't know. I don't have the same experience as them, but I'm genuine and I'm supportive and I'll ask them about it and they'll tell me. And then I know it from there, so I can be helpful. Don't be afraid to ask those questions. Respecting autonomy, again, supporting your patient's choice without moralizing the medical care that you're giving them. Continue to evaluate your own biases. We all have them, period. We all change throughout our lives. Those biases change throughout our lives. We are always having to evaluate that. And you need to understand the power dynamics and the words that you're using as a medical provider. You may not have white coat syndrome where you walk in and get scared of the doctor, but a lot of people do, right? And so knowing that is important and respecting that and making sure you're not using that power dynamic in a bad way. And then meeting people where they are and celebrating all positive changes. Again, it doesn't matter how big or how small it is, celebrate it with them. It's not hard to tell people, that's amazing, that's good. You see 10 patients a day, they see one of you, right? So it's a very important interaction for them. So support them in that. Next slide. And so, yeah, this quote, one of my coworkers found, and I really loved it. So, harm reductionists accept that people use drugs and that some struggle with addiction. We want people who are using drugs to stay alive and as safe as possible, and we will help them regardless of whether they quit. Cutting back is recovery. Using more mindfully is recovery. Switching to a less risky method of ingestion is recovery. Any improvement, however seemingly minor, is worth celebrating. Total abstinence is not the only valid path, nor even the best path for most people. So hopefully today it at least opened your eyes or ears or something to what harm reduction can look like in a medical practice besides just at a syringe exchange. Um, Again, I didn't know of any of this when I was working as a nurse before here, and it really honestly made me feel like this is actually the most holistic type of medical care you can get, is a harm reduction approach to it, which I think is a good thing. So yeah, please reach out if you have any other questions. Obviously, I'll take questions now too, but shoot me an email if you want some other stuff.
Great. Thank you so much, Greg. If we could just take a moment to, you can react with a round of applause or anything like that. We just really appreciate your time and speaking today. We will open up to questions. There's multitude of ways to ask questions or chime in. You can use the chat like you all have been using. You can ask your questions there. You can raise your hand and unmute and ask it verbally, or you could also use what we use for kind of more anonymous if you're kind of a little bit more timid at asking questions in a larger space, Menti. And so you can do that by, can we go back just one for the QR code? You can scan that QR code if that's helpful for you. You can also go to the link that I believe, yep, Anastasia put in the chat, as well as you can go to menti.com and type in the code 23110331. So we're open to questions for Greg. So the first one I see is, what surprises you about your job?
Um, I think the thing that surprises me most is how once you start having honestly just open, supportive conversation with somebody, that as a nurse, I'm like, hey, I'm a nurse, can I help you out with that? Or like as soon as I show someone that I actually want them to have less harm, but also I'm not saying you need to stop using drugs, how immediately someone opens up and then starts trying to tell me everything like I'm their full provider. I'm like, I am not your doctor. I can't do that. But it's how quickly that trust goes from people not being heard and respected by medical professionals to as soon as you show just a little bit of compassion and care, it just opens up immediately. And so it surprised me not how like it's easy to befriend people, but how easy it is for me to respect people and how fast they open up. And I wish I would have done that earlier in my career.
Another question. How do you like to address on-site learners who may be using stigmatizing language in front of participants?
I'm like nursing students, maybe I'm assuming that's what that is. So we talk whenever we have like volunteers or people, we always do kind of a quick little rundown on what harm reduction is if they don't know already. And there's kind of brief little harm reduction 101 that we do, and I bring up language and stuff during that time period. And then our team is really good that if someone says something that maybe like that, we'll politely pull them aside, have a conversation with them about it, and just explain like what what they said, why we try to avoid saying stuff like that.
And maybe to like tease that out a little bit more too, other staff that might be not as, into harm reduction or understand these nuances, and you're hearing that language, how you might address maybe even just some of your colleagues too, maybe outside of the SSP, but in other spaces.
Yeah, so our whole company's done harm reduction trainings and that type of stuff. And like whenever we get new hires, also everyone shadows every different department. So if you come working for our company as a case manager, you also spend a day with the syringe exchange to kind of get that. And so our company's done a good job of talking to people and training people. And then if you run into a coworker that's saying something or you're just saying something that you would be like, hey, don't language, whatever. It's just a polite conversation, pull them aside, and we've never had any issues that way. But
The next, oh, sorry, go ahead.
No, go ahead.
The next one is around naloxone, and I do want to put in a quick plug that we will be having a session on naloxone as well. But if you wanted to say just a little bit more about naloxone and who to prioritize giving naloxone to, is the question.
Everyone should have naloxone. There's no reason not to have it in your car. Good Samaritan law protects you from giving it to somebody, so everyone should have it. There's enough of it; it should be given out. But differences in naloxone. So I'm happy. I know we're doing the conversation later about different types. But basically, there's nasal or an injectable. The injectable ones are temperature safe. Those are the ones that are great. You can leave it in your car. In the winter, it will not freeze, and the summer doesn't get too hot. The nasal ones, unfortunately, if it gets above a certain temperature, I don't know off the top of my head, it will leak, and so it won't work properly. Or in the wintertime, it freezes, so it won't vaporize properly. So that's the issue with the nasal ones. Dosing wise, there is the normal one's 4 milligrams, like the brand name Narcan, and then an 8 milligram one came out called Cloxato, and then now a new 3 milligram one came out called Revive. Don't really know. There was a study that was done, I believe, in New York that actually showed that the 8 milligram one had no more successful overdose like prevention. It didn't save any more lives, like 0%. But it did cause way worse withdrawal symptoms, which people are more likely to use afterwards, which actually did increase death rate. And so that's why we don't recommend the 8 milligram one to people. We recommend like the 3 or the 4. And then if you're comfortable using the injectable one, just because it's easier to transport and have in places, the injectable one's great also.
Great, thanks for that really brief background. And we can add some resources as well in the iEcho platform today. And also, Greg, because you had mentioned sources for some of your slides, if you want to send us those, we can pull them for you too and add them to the Echo platform.
Will do.
There's another question. We'll probably do a couple more questions and then move into our case presentation. But do you know of any plans to expand services offered at Choice Health in Cookeville?
I am the nurse. I am the nurse on the team. I do not do any company planning or any of those things. So my
Well, it
answer is
sounds
I don't know. No.
it sounds like there is some interest in expansion, maybe harm reduction in
Yeah.
general. And so if there's any SSPs on the call, maybe worth reaching out. We'll do a kind of a last call for questions for Greg. Okay.
There's a question in the chat.
Yeah. In your experience, how/when do you broach discussions about traditional/absence-based treatment?
When people ask about it. So my experience has been people come into the SSP, like the exchange. We have resources for everything. We have resources for a lot of different stuff, right? Everything is opt-in. And so if someone comes in and says they want to go to treatment, our answer is okay. How do you want to go? And then we have a realistic conversation of what that looks like for them. Can they get off work for 30 days to 90 days? Can you get away from your family? Do you have the money? If you're doing all those things, we try to make the environment as open as possible. So when someone wants to go to treatment, they'll ask for it, because our experience is that's what it is. If someone wants to go, they'll ask about it. And then if someone does go, and they come back and they 6 months later we're like, hey, where you been? And they're like, oh, it's a treatment. Our response isn't, oh, why are you here? It's like, oh, well, I'm happy you're here. I'm glad to see you. Because we want them to be safe. And so if you're not trying to get people to the next day, if you're not being supportive of that, that's the most important thing. But yeah, we don't broach the conversations until someone brings it up, and then we gladly have a conversation with them.
Awesome. Great. Well, thank you all for your questions and Greg for your presentation answering those questions. Greg was generous to share his email, so if you do want to reach out, I believe Anastasia added in the chat and we'll get it in there again. And these slides will be available after the session as well as the recording. So at this point, we're going to stop the recording to move into our scenario to really have that open, honest place for discussion as well.